There we go. Pardon. So we've got Dr. John Campo. He serves as Kennedy Krieger's Vice President of Psychiatric Services and the Director of Mental Health at Johns Hopkins Children's Center. He's well known for his research on the integration of pediatric mental health services in general medical settings and the study and prevention of suicide in children and young adults. Dr. Campo has been honored with a number of accolades, including the American Academy of Child and Adolescent Psychiatry Simon Weil Leadership in Consultation Award and the National Alliance on Mental Illness Exemplary Psychiatrist Award. He has also been on America's Top Doctors list for a remarkable 18 years. Thank you for being here, Dr. Campo. And secondly, Dr. Carmen Lopez Arbizu serves as Kennedy Krieger's Medical Director of the Psychiatric Mental Health Program, an Assistant Professor of Psychiatry and Behavioral Health Sciences at Johns Hopkins School of Medicine. She is also a member of the faculty at Johns Hopkins Hospital. Dr. Lopez is most well known for her unique approach to the psychiatric evaluation and treatment through interdisciplinary and multidisciplinary programs at the Institute, collaborating with programs such as our pain rehabilitation program, our outpatient neurological behavioral unit, and she's a passionate educator and advocate for the importance of training future child psychiatrists. The emphasis is to learn how to evaluate and treat dually diagnosed children and complex care patients, which is a specialty of Kennedy Krieger Institute. Thank you for being here, Dr. Lopez. So I will turn it to Dr. Lopez and Dr. Campo. We're eager to learn more from you. Again, we're grateful for all of you being here today. So without further delay, Dr. Lopez, Dr. Campo.
Thank you, Linda. Thanks for the kind introduction. And it's really a privilege for me, and I know for Carmen, to be here with this group. And we do want this to be, yes, we're on Zoom. So, here we are still. I think I came here to Kennedy Krieger and Hopkins about a year ago, and I thought that I'd be back to regular meetings in about a month, but here we are. Thank you for your interest and your commitment to this area. A lot of times in the academic setting, we always talk about a tripartite mission, clinical service delivery, education, and research. But I actually, when I've talked about it, certainly for what we do, I think there are 4 parts to it. And in addition to clinical education research, I think advocacy is an incredibly important part of what we do in the behavioral health field. And it's really a privilege to be here with so many people who have sort of adopted that stance, because there's so much that needs to be done just on an advocacy perspective. I think a lot of what we do is being analogous to where cancer care was many, many decades ago, where there was a tremendous amount of stigma attached. And I think we've seen just the incredible changes that have happened in cancer care. And we're hoping for the same. So really, I'm going to maybe ask Dr. Lopez, Carmen here. We've both been sort of trying to adjust and learn during the pandemic. And I guess maybe it would be reasonable for us to begin, Carmen, with me asking you, you've been on the front lines during the pandemic and doing a lot of very important clinical work, and have demonstrated a lot of flexibility. I'm wondering if maybe you could share a little bit about what your experience has been during the pandemic.
Yeah.
And then maybe
absolutely.
put that into the context of the reality of mental disorders in the United States right now.
Yeah. So, we want to try this to have this conversation in a way that it's helpful for you to understand what we do in the simpler terms. So definitely the mental health field has been in demand for children and adolescents for a while now, and there has been a significant shortage of medical providers, especially child psychiatrists, but also some other specialists, especially for the complex cases. COVID hit us very hard because that increased the demand for our services in a way that I don't think we were expecting it. We at Kennedy Krieger, and I'm going to talk a little bit about what we do in our program, is that we were able to jump into telehealth in a week. Like, this stuff started on a Monday. By the next Monday, we were full on telehealth. And, talk about front lines. I tell our staff and people in my clinic, and a lot of us is like, a lot of things were on hold. We were never on hold. I think the workload increased for us so much more in patient care and in patient intensity because all the other supports in the community were gone. So we were the only lifeline for many people. So telehealth allowed us to be more efficient seeing patients, but at the same time, that allowed us to see more patients, which is great, but it increased the caseload in our therapists and in our physicians. So yeah, it's been a hard 18 months, but despite that, we have been able to do very well. One of the things that we have noticed in the demand is a lot of depression, a lot of anxiety, and a lot of behavior complications that are not necessarily attached to any particular mental health diagnosis, but more on the adjustment side of, when you're a teenager and you used to be just out in the community and having friends, and now you're having all these limitations and you have to stay in your house and you have to follow these rules. So it made family living a little bit more difficult, and a lot of parents were trying to reach out for support and help how to just manage and adjust to the changes we experienced. So yes, definitely we have been very, very busy, and we have been able to serve a lot of families, and we definitely wish we would have the ability to serve much more. That's what we have been seeing overall.
I think one of the things about the pandemic is it challenges us. I mean, I'm flattered to be labeled here as an expert, but I most certainly don't think about myself as an expert because, quite honestly, I don't think we know enough about pediatric mental disorders and their implications for any of us to go waving the expert flag. That said, I think the pandemic in a lot of ways has really helped people understand a bit about how much of medicine in general and healthcare in general involves learning and adapting as we go. And I think we are certainly trying to do that in the mental health sphere. Carmen, I know that there's been a tremendous amount of demand. Do you have a sense of whether demand or need has increased, or has it really been hard to say?
I think both, but one of the things that has happened is that this actually was an opportunity for people to be able to open themselves up and to discussion about mental health. There's so much stigma about it. People do not want to ask for help. They're afraid of ask for help. They're going to think I'm crazy. And it's just difficult to connect and find services at the same time. So the conversation of COVID and the ability of people to relate to others about their difficulties that they were having kind of increased the opportunity for patients, for families to kind of say, you know what, I do have an issue and I need help to get over this. And it kind of allowed open the door for access to
I
help.
think that's a really important point. One of the things I remember being asked about this issue, it's like, are things actually worse for children during the pandemic? Are children at greater risk for suicide during the pandemic? Mm-hmm. And my first response, before I talked a little bit about what we know and what we don't quite know yet, was to say, well, here's the one thing that I can say quite confidently. These issues have been a problem for a long time, predating the pandemic.
Oh, yeah.
And that suicide rates in young people have been increasing for well over a decade prior to the pandemic. What the pandemic helps put into perspective. I mean, I just said this the other day, you know, when you look, I mean, I know that Linda had mentioned that one of my interests is suicide prevention.
Yeah, Linda, can you put up that slide, number 5? What are the risks? I think that really, gives a little bit of
Yeah.
in numbers, what
Okay, so
we're talking about
this slide tells a little bit about mental disorders
in
being
general.
quite
The next
common,
one. Mhm.
about 1 in 5 of us at any one time, and probably about 5% of adults in the country suffer from a serious mental illness where they're seriously impaired, maybe can't even work.
Mhm.
So the disorders are common. Both Carmen and I have invested our careers in really working largely with younger people. And one of the things that this slide also points out, if you look at the bottom, if you look at serious mental illnesses across the lifespan, 50% of them have actually presented or at least begun symptomatically prior to age 14. 75% have presented by
Yep.
young adulthood.
Mhm.
So
And
what's interesting is these disorders, they start early. Oftentimes they're not recognized though. And interestingly, if you look at time from onset of illness to recognition, it's much longer for children and adolescents than it is for adults. We don't do as good a job picking it up in kids, probably because we think of kids as somewhat different.
yep, and
Um,
that's just little. And one of the things is that this can be a chronic illness that literally stay there for years and years and years, especially if not identified.
that's
But
right.
also, it can have mortality consequences that are very severe. Can you put the next slide? I'm sorry, Linda, please.
Yeah.
So this is what Dr. Campo is an expert on.
Well, yeah,
So
again, don't call me an expert, but because we aren't doing so great. If the suicide rate was coming down, then I maybe feel better about it. But yeah, one of the points that I made is that if you look at school age children and adolescents, across the lifespan, suicide is a major public health problem. It's always among the top 10 causes of death, not just in the United States, but across the world. But if you look at younger populations, suicide has a much greater impact in younger populations than in older. It's the second leading cause of death between the ages of 10 and 34. What I'd also point out is 3/4 of the deaths or thereabouts in children and adolescents are caused either by accidents, number 1, suicide, number 2, and violence, number 3. All of the other things that you hear about in the children's hospital telethons, if you did a pie chart, the pie chart, there'd be one little slice, about 25% of the pie would be just about everything else that kills kids. So suicide by itself kills 20% of school-age children who die, right?
Mhm.
That's more than that's more than deaths from cancer, from heart disease, from respiratory disease, from infectious diseases of all causes, including COVID, right?
Mhm.
Diabetes, HIV, everything else. Suicide kills more kids in that age group than all of those things added together.
And there's a
So
question in the chat
yeah,
that one of the things that what is a broad definition of mental illness for the context of this discussion? And I
okay,
think
yeah,
Mhm.
please go
Okay.
ahead.
So, one of when we talk about mental illness, it's a definitely a very long list of things. So we're talking about ADHD, depression, anxiety, post-traumatic stress disorder. We're talking about bipolar disorder. But we're also talking about a lot of other that are a combination of more than one, which because we sadly see a lot of comorbidities. In the institute, we see, we are a rehabilitation hospital. So, and our tradition focus has been the population with developmental disabilities or related disorders. And I think one very important thing that I always try to communicate to people is that having a developmental disorder does not exclude you from having a psychiatric disorder or a mental illness, but actually increases your risk of presenting as such. So we see a lot of patients from the other medical clinics and programs in our clinic as well. You can have traumatic brain injury, autistic spectrum disorder, anything, and you can still present with what we call a mental illness. And I don't like that term, but that's kind of the term that it's used because mental illness might imply some negative
well, but it is an illness, right? And yep. I actually think, to get to the question, I think it's an excellent question because, when you talk about these problems, we need to at least have some precision in what we mean. And when we talk of a mental disorder in general, what we're talking about in a very simplistic way, and it can be challenging, but in a very simplistic way, we're talking about some disturbance of emotion, of thought, and or of behavior that's associated with some sort of meaningful disability and impairment. That's a very general, very simple definition, but it gets to it. When people ask me, what is psychiatry about? We're the medical specialty that's primarily focused on disorders of emotion, thinking, and or behavior. And tremendous amount of overlap with what our friends and colleagues in neurology do. And I think there will be more and more as time goes on. But that's a great question. And that's what we mean by a mental disorder. That's where simple sadness is not a mental disorder. We're talking about something that has impairment over time. What's also true is that a meaningful diagnosis should have some sort of predictive validity, right? It should say something about expected course and prognosis, and ideally about inform us about treatment.
Okay. Can you move to the next slide? And one of the things about why does it matter? Why does it matter that we identify and treat any kind of mental illness? Yes, because of the mental illness, because it affects quality of life, but because it also, untreated, turns into a disabling event that affects quality of life, but other systems in the person that it's affected. So we know that depression, people with depression have a 40% higher increase in developing any cardiovascular or metabolic diseases. They're nearly as twice unlikely to develop these conditions. The other big one we have is substance abuse disorders. We know that 18% of the adults with mental illness also experience substance abuse disorder. That also implies effects in other things like society and functioning in long term, which the rate of unemployment is definitely higher on adults that have mental illness compared to those who do not. And the way where we can make a difference is addressing that before they get there. High school students with significant symptoms of depression are more than twice than likely to drop out compared to their peers. And students ages 6 to 17 with mental, emotional, or behavioral concerns are more likely to repeat or not learn what they're supposed to learn in their grade they're assigned to. So we can make a difference addressing treatment early on in the family's quality of life, in the child quality of life, and eventually, all of this affects us as a society as a whole. So early intervention has, we talk about that about education. We talk about that in identifying any kind of, disability issues. It's also important to identify early presentations of any mental illness to address it and have an effect before it affects quality of life and long-term effects.
I think that so much, and we really very much feel like we're likely preaching to the choir here, but there's something about creating a sense of urgency here because we've not been thinking about these problems correctly over the years. And to come back to the pandemic, last year around, somewhere around 7,000 children, adolescents, and young adults died from suicide, okay? If there was an infectious disease that was killing 7,000 children and adolescents a year who were showing up in our emergency departments, you can bet that there would be a very dramatic, organized, systematic response to this public health challenge. And yet that's not how we've responded to the problem of suicide or to the problem of mental disorders in general. Why? I think largely because we think differently about them, largely because we reimburse care differently. And much of that comes back to the to what you began with, Carmen, which was talking about the whole issue of stigma. Mm-hmm. We are doing better now, and we're talking more about these disorders. But we can't pretend that stigma isn't real. We're all influenced. All of our thinking is changed by this. Mine as well. I'm supposedly a true believer, but it's easy to have it's easy to become complacent that how we do things are necessarily the way things need to be done. So one of the things that we're really committed to at Kennedy Krieger right now, and I think this really comes from the top, is how do we look at problems in a new way? How do we think about these problems as disorders of the brain, but not just disorders of the brain, human problems? And how do we not just care for the patients in front of us, but come up with new ways of caring for people that are superior, and at the same time train the next generation of providers and advocates?
Mm-hmm. I think you mentioned one of the things that as part of our mission, it's education, research, and clinical care. And one thing, and yet I'm totally bragging because I'm very proud about this. So we work very closely with the Hopkins Child Psychiatry Division, and we are very committed to training fellows to be able to be to replace us one day, to be the new child psychiatrists of the future.
Sooner as opposed to later for me, Carmen.
Well, you wish, but we're not going to let you go. There aren't enough of us, and it's just so amazing that we are able to train them. And just so you have an idea of why are we here? Because we can be anywhere, right? Why are we here? When I came to Kennedy Krieger, actually I came to Hopkins because of Kennedy Krieger. I came to do my fellowship to Hopkins because I wanted to be here. And this is where I wanted to be. And I think, all of us are into psychiatry for one reason or another. And, some of us have like our personal mission of making a change in the things we believe in. So, we can talk to you about mental health, we can talk to you about diagnosis, but you should also know that there's a personal investment of the people that are here and that work here to make things better for our patients and to make things better, not only in one person at a time, but in the systems of care that needs so much adjustment and education about what mental illness is, and take away the stigma and educate parents, families, also the other systems of care about the needs of our patients.
Dr. Lopez and Dr. Carmen, or excuse me, Dr. Lopez and Dr. Campo, a couple of questions. Could you touch on really the interdisciplinary approach and how that's unique to Kennedy Krieger? And someone submitted a related question that is, you're talking about treatment. Is Medication paired with therapy is still the best combination. And again, the complexities of care here at Kennedy Krieger.
A really, really great question. You know, and Carmen, please chime in. I mean, the reality is, again, I think the questioner knows that a lot of this does vary by diagnosis. We're making progress in learning more based on scientific evidence about what works and what doesn't work. Not that long ago, we didn't have much evidence of anything other than anecdotal evidence. Then we reached the point where we're able to say, let's pick depression, for example, or anxiety. I think both very similar, where there was a time we could say, you know, we have good evidence that psychotherapy is better than no treatment. We have good evidence that certain antidepressant medications like serotonin reuptake inhibitors like fluoxetine or Prozac are better than placebo. But at that time, we weren't really able to say, is one treatment better than the other? Is the combination better than either or? Now there's some signal for anxiety and depression that the combination may have certain advantages, maybe not over an extended period of time, but certainly in terms of getting people better faster. There is so much that we don't know in child and adolescent psychiatry. Now, what's exciting too now is that in addition to medication, in addition to some of the really well worked out behavioral interventions and cognitive behavioral and psychotherapeutic interventions, increasingly now we have access to a number of somatic interventions that we hadn't even thought of so much with kids. They're not used all that much, but things like electroconvulsive therapy, for example. There is a small but very needy group of children who could benefit from this. Catatonia is an example. There are a number of techniques now that are experimental, like transcranial magnetic stimulation, that we're learning more and more about and may have application in a variety of disorders, including autism, depression, OCD, that sort of thing. And then there are these rapid interventions that we're just trying to understand, things like ketamine and esketamine. So we are, I think that psychiatry in general is a bit behind, I mean, clearly a bit behind the rest of medicine, but not as far behind as one might think. So I don't know if that's a useful answer to the question. Carmen, you want to add anything to that?
No, and one of the things that addressing one of the questions is like any suggestions about how to talk about mental health. And one of the things that it's very true. You hear about surgeons and you get Grey's Anatomy, but you hear about psychiatry and you get Cuckoo's Nest, whatever is the movie. So it's like this the stigmatization of psychiatry. It's horrible, but and I make this joke not in a very funny manner, but everything is fun and games until somebody you love needs care. Then it's not funny anymore. And I think that we should not always stop the jokes, but we need to make sure that people understand the severity of this, and the stigma should not get in the way of accessing care. I think it's important. There was a lot of bad stuff about COVID, but it also allowed us to be together as a family because you had no other people to talk to. If you wanted to see another human being, it had to be your parents or, and your teenagers. And that opened the opportunity of having dinner together again. And I think those conversations need to be at the table. We need to go back in time and bring back that openness. Parents need to be very, very aware about all the social media stuff. If you have children or even grandchildren, you need to know what TikTok is about. You need to know what Snapchat is about. You cannot be behind in times. And, one of the things that it's also kind of following this is what's the difference, between being a pediatric and an adult psychiatrist. So I'm both. Dr. Campo is on top of that. He's also a pediatrician. So, he just wants to be better. And I think we go over, we train first in adult psychiatry, and child psychiatry is a subspecialty. The big difference is that children are not mini adults, period. Big difference. The training about development, so you need to be able to understand emotional development. You need to understand school systems. And you need to be able to work with your patient and everything that surrounds the patient, which is
I'm
very
still
different
not
from
doing,
an,
I'm not doing Snapchat, Carmen.
I-
Sorry.
yeah,
No
I know.
Instagram, no Snapchat.
No,
Ain't gonna happen.
we need to get you on that.
No way.
Because it's you need to be able to connect everything that surrounds the child. When you treat an adult, many times you meet nobody else but the adult. When you meet a child, you need to be able to navigate, communicate, and adapt to the surroundings, meaning parents, school, friends, and you need to be very attuned to the developmental age. Now, as a child psychiatrist, I don't do therapy. I do the evaluation and the rest of the parts. So I have to also be very aware and connected with the psychotherapist, because you cannot work on a silo. You need to work as a team with all of these groups.
Thank you,
I don't
Dr.
know if that
Lopez.
answers help.
I know Sheila Schlager had a question.
Michelle.
Is it helpful, or would it be helpful to trace the disorder back before the pandemic to see how it escalates or develops, changes, becomes more complex, more serious? Is that something that you will be doing to make
Great question. Thank you, Sheila. You know, I'll give you a specific example. I mean, I think that several disorders, I don't know if it's going to turn out there's a big change or not. These things are hard to sort out too over time. What I can tell you is that certain conditions that we haven't seen a whole lot, we're seeing more during the pandemic, and I can't tell you why. So, for example, probably in the last year, I've heard about and seen more cases of a condition called catatonia in children, in adolescents, than I have seen probably in the rest of my career. And I'm old, so that's saying something. So, so the question I'm sorry.
I said, now, don't.
Yeah, I'm joking. But you know, the question becomes, is this a real change? Is it that we're paying attention more? So one of the things that I'm doing with a colleague of mine who is very, very good with huge data sets and claims data is we want to at least take a first look and see what has happened with regard to claims for presentations that involve catatonia over the last decade or so. Is there a change in the slope of the line, you know? I think certainly with suicide, these questions are hard. I know that many of us were terrified that the isolation would result in an increase in the suicide rate, legitimately so. You know, the early parts of the pandemic, interestingly, the data we have so far, early on, maybe not as much of an issue as we had been concerned. But you know, it's hard. Yes, sometimes data can be confusing. What we're finding is that even though traditionally suicide rates in Black kids have been lower than in white kids, and in certain minority populations have been lower than white populations, it looks like during the pandemic, the rate of increase has been more in minority populations. And, you know, it stands to reason that those populations may have been a bit more vulnerable during the pandemic. So there's a lot, I think there's a lot of work that needs to be done. But right now we're trying to fix the car going down the road, I think.
Three related comments. First of all, I don't know what catatonia is.
Yeah. I'm going to let Carmen explain it because I'm not smart enough to. I'll tell you in a minute.
So,
Okay.
go ahead.
And the second, is there a significant impact because there's a difference between actual age and mental age?
Hmm.
Do
That's
you
good.
understand the question?
Or maybe I'm not sure I'm understanding the second one.
You mean the relationship between actual age and mental age?
Yeah.
Because children are a certain fixed age, like 7,
Yep.
but behaviorally, intelligently,
Yes.
aggressively, they're 10 or 11 or 12.
Yep. Sure.
So this dichotomy or this divisive, or I don't even know the word I want to use, this difference certainly can make an impact on a child's understanding of his or her behavior and of the parents'
Yes.
understanding of his or
Absolutely. Yep. Great. Yeah. So, might the pandemic be more of a challenge for kids who are intellectually disabled, for example? I mean, one of the things that we do know, and Carmen is really, Carmen has really devoted much of her career to dealing with psychiatric problems in kids with intellectual and developmental disabilities. We do know that those kids are actually more vulnerable to mental disorders rather than less. And I think that it stands to reason when you think about a lot of these disorders are disorders of the brain, right? I always tell the story that early in my career, one of my first jobs was developing and running a med psych unit for kids, right? So we had kids who had medical and psychiatric problems together. And in the beginning, I think everyone anticipated that the number one population on the unit would be kids with diabetes. Well, diabetes was number 2. Number 1 were kids with neurological conditions, epilepsy being the most prominent. So if you look in general, chronic physical illness is a risk factor for mental disorder, but physical illness that affects the brain, huge risk factor in comparison. Carmen, you want to?
Yeah. So, that other group, I mean, we definitely see the ones in the developmental disabilities world, all the patients with CP and those, but also we see so much need on the people with chronic pain, with POTS, with all of those, kind of functional neurological disorders that have so much effect in quality of life. A lot of them have comorbidities in mental illness. So we see a huge demand in that group as well. But yes, we have definitely seen, going back to the developmental age and the real age, is that yes, we have to adapt in a way to connect with these patients and adapt the therapy and the services to them. We definitely want to continue to focus on education and treatment of these patients because out in the they come here because we understand them, and are we special because of that? Absolutely. I can say that I'm very proud that we are special about that we are able to connect with them and the families and understand. And many times what we hear is like, you get it. Have you ever seen this? People don't believe me. And yeah, we see it every day. This is what we live and breathe. So, I think I'm totally losing the track of what was the question, but, I thought that was a good point to bring. Sorry, go ahead. More questions.
I think the issue of, getting back to the whole issue of mental health in general and behavioral health in general, I guess the way I'd say it is one of the problems in our field over the last probably 100 years, if not the last 50, has been this the guild issues that develop within given disciplines. Psychiatrists think that we're the group that can do it all. Psychologists think we're the group that can do it all. Now nursing and social work. The reality is, if you want to know how I've been thinking about it and how we think about it here, I think modern behavioral health care is interdisciplinary by definition, right? And what I mean by that is that excellence in care is usually delivered by teams. That doesn't mean that every kid has to have their own psychiatrist, psychologist, social worker, nurse, occupational therapist, counselor, whatever. But what it means is that those of us who are working in this field have to be part of a team and have an understanding of our own skill set, our own role definition. Pretty much everyone on our team has to be able to provide a high quality assessment and at least a good enough assessment to know when they need more. I think I can do a pretty good initial assessment, but I'm not a neuropsychologist. If somebody needs that level of testing, I have to know when to hand that off. Similarly, I might see a patient with obsessive compulsive disorder. It's important for me to know all of the different evidence-based treatments that are available so that families, so that we can create informed consumers of care, so that patients and their families know what's available to them. Because I might think that the child should begin with cognitive behavioral therapy or with Prozac or something like that. But that's the most important thing, is that we can help patients and families make an informed choice. That doesn't mean that we're going to go along with doing something that we think would either be a waste of their time or worse, dangerous. But it allows us to really partner with people and provide the kind of care that I think people should have, which is interactive and a partnership.
Yeah, and I think the one thing that you mentioned that is so important, it's evidence-based treatment. As somebody that has been doing this for a while, nothing like scares me more when somebody says, like, well, I'm doing my therapist, and what kind of therapy are you doing? Eclectic. I'm like, oh my God, I don't know what that is. Literally don't know what it is. So if you have OCD, there's specific treatment that I can prescribe for you that is this kind of psychotherapy. So wishy-washiness, well, you can do it, but it's not going to lead you anywhere. And I think those conversations are important to have. That's my role. My role is to inform you. These are the treatment options. Which ones do you want to go for? And let's do it together. And I'm sorry, Linda, you have a question. Go ahead.
Yes, from the group. I'm conscious of the fact that we have our board chair and expert in childhood education, Dr.
Yes.
Nancy Grassmick, on this call
Nice.
as well. And so wondering about what are you seeing as it relates to mental health in our schools at Kennedy Krieger, the needs there for our children, as well as, any larger environment in the region. So is that shifted? I would imagine, as the question goes, there's more demand for mental health services in our schools.
So I see a lot of the kids from the schools, from the high school and from LEAP. So I if I had a magic wand, I would like them to be able to receive more treatment there because of there's the presentations of the behaviors can be very tricky to manage in a regular clinic setting. So if I had a magic wand, that's what I would have, to have more child psychiatry presence and treatment in the school setting. But, I don't have that. But John, what do you think?
I think that what's the advantages? When we were really trying, an area that I've always been very interested in is how do you improve access to care, right? Because most kids with mental disorders either don't get any treatment or they get inadequate treatment, right? They either get treatment that isn't appropriate, or they get treatment that is appropriate, but not at an adequate dose. So when we asked this question, when we were going at this, where are the two places where the kids are, right? Schools are one. And then the other place we focused was primary care. Schools have great advantage. For the kids who are at Kennedy Krieger, our schools really need to be, I think we have to integrate access and services in a way that's superior to any place else. That said, if you look at society in general, I think it depends what community you're in. A lot of people are big advocates of school-based clinics and that sort of thing. But in some communities, parents and families don't necessarily want that so much. They want to keep that separate from the educational setting. So, I think a lot of it comes down to what do parents and families want and what works out best for the kids. But it is greatly advantageous to have those services available in the schools, and not just psychiatrists, but behavioral interventions, maybe even more important.
Mm-hmm. Yeah.
Any other
Linda?
questions from the group? Yeah.
Linda, since you mentioned that I was on this, and I really want to thank the two presenters, such valuable information.
Oh, thank you.
But during my career, at one point, I was working with children in the juvenile justice system, as well as being in charge of a school which had 200 children with I would say emotional disorders along the continuum, but some very severe. One thing that I hope would happen is that information could be imparted to teachers. Because when I sat with children who were in solitary confinement at 11 years of age, and I asked them over time, why are you here? If I were to condense everything that was said to me, I knew that I had problems when I was in second grade, and I was made to feel like a failure, and there was no hope for me. The idea of teachers who touch the lives of every child, having this knowledge that you're imparting, I think is so critical.
Well, thank you, Nancy. Nice to meet you. I think that I think the other thing you said is how important it is from teachers to also those of us who are professionals, to everybody that comes in contact with kids and with families who are dealing with kids with these kind of problems. The idea of making sure we instill hope and positive expectations is critical. Because I think there's this myth that, oh, if you have these problems, nothing can get better. Most of these problems are or tend to be chronic, but so is asthma, right? And I know, getting back to one of the questions that came earlier about how to talk to kids about it, one of the things that I try to do, oftentimes asthma is a very useful analogy, because it's like, asthma is interesting. If you have any friends with asthma, you know that you're vulnerable to start to wheeze, but a lot of times there's a trigger, right? There might be an allergy, it might be cold, you might have an infection. You have the vulnerability, and then there's the trigger. And for some of us, asthma, you deal with the episode and it goes away and you're fine. But for most of us, you're vulnerable to have more. So, and that's so true for these emotional and behavioral disorders. So how do you educate kids and say, just like your lungs can be super reactive, our emotions can be reactive in one direction or another. Our thinking can get distorted in ways that maybe aren't good for us. And it's just a matter of us learning about that and how it affects us, and then trying to connect with people to help us manage it, just like we would try and manage our breathing with asthma.
Yeah, and I totally agree. I think, the issue about, it's not about just the child isolated, it's the surroundings. So, we see this also with other kids, like, they cannot go to the pediatrician's office because they have an issue. So we have to, or somebody that, it's a 19-year-old huge kid with diabetes and cannot get a proper food examination because of the behaviors. So I think one part that we need to do better, and by we, like in the royal we, in the Kennedy we, is to educate the population in general that, our core, set of patients are growing and are having a life expectancy that it's longer than before. And the labels, stigma, complications are getting in the way of them accessing appropriate care, healthcare in general, mental health as well. So yeah, we definitely need to do more outreach in educating the public. And, this one about how are we doing in Maryland? So, it's, I don't know if you can see the little letters there, but, we're not doing super bad. However, it's, we see a lot of kids that are close by, and I worry a lot because I have kids that they drive over from Salisbury, and even though Maryland is so small, Salisbury, to coming to see me is in the other side of the world, literally. And if it's in January, they cannot cross the bridge. So it's, we need to do better. We need to do better in educating. We need to do better in extending our services. I need more than one magic wand apparently, but I have to say that we have lots of ideas. We wish we could develop them, and we have the passion. We just need to continue to work on it and educate the public.
That's been one of the things that's impressed me at Kennedy Krieger. There's a tremendous amount of passion, and I think that it's true at the highest levels of leadership. I think that one of the things that was very compelling for me in thinking about whether to move to Baltimore and take this job was just how impressed I was with the heart of the leadership at Kennedy Krieger and also at home.
And he moved here when there was no traffic, so it was funny. But now there's traffic,
Yeah.
so he's learning what it really means to be in Baltimore.
There you go.
Bridget, you have a question. You want to say it?
Yes. Hi. I know we're coming up on time, but I just wanted to hear from you both. First, thank you so much for everything that you've presented already. But I know that we are trending towards better acceptance of mental health, the importance of mental health, rather. So what do you hope to see as far as prevention and treatment of the challenges surrounding mental health struggles?
Thank you for the question. I'll start, Carmen, and you can go from there. I guess it's an interesting thing. On the one hand, I want people to be very open about. I want to do everything we can to destigmatize the idea of talking about and asking for help. I want to destigmatize intervention and treatment. At the same time, what I don't want to do is find a way to encourage disability and distress, and let me be more specific about it. When you look at the problem of suicide, right? We don't want people to feel stigmatized about presenting for help and talking about the problem. But do we want people to think suicide is okay? Hell no, right? So it's an interesting balance. How do we help people maintain their passion that these things are really negatives that we need to be locked at the elbow and marching against together, just like we've come together to fight cancer, while at the same time saying, if you have this problem, it's nothing to be particularly ashamed of, but it most certainly is a problem that deserves attention and that deserves us to get mad about it and to be as aggressive in taking it on as possible. Because one of the challenges we have now is that we aren't doing that. We have, our public health response is not anywhere near at the level of the public health impact of these disorders and problems. So how do we align our passion, our energy, our anger, if you will, while at the same time opening the door and being welcoming to folks? Carmen?
Yeah, no, I think a lot of our role is to give hope to people that there's help available. They have to make an effort. I think we have to empower them to be able to reach for the help. There's a hand, go for it and grab it, and let's move on together. I think it's important to know also that mental health is, I make joke about this because it's like diet and exercise. There's no magic to this. This is something that you need to be consistent about, and this is something that is going to take time. It doesn't come up in one day, and it's not going to go in one day. So, we need to level expectations, and we need to have an open communication with the families about availability of treatment and what are the expectations and the goals for treatment. Mm-hmm. Yeah, and did we talk the whole hour? I couldn't believe it, but yes, we did.
Yeah, that's not surprising for the two of us, Carmen.
I know, John. We're terrible.
I always joke when I was a little kid, my mother would say things to me like, enough, my ears hurt. Like, were you vaccinated with a phonograph needle, was what she said to me more than once, which was.
And I think she was right.
Yeah, I know.
Any questions, anyone? Well, and if you have any later on, feel free to reach out.
That's the other thing for the folks on this call. I do hope, I think Linda and Bridget can make any of my contact information available. I'd be delighted to hear from you. Suggestions, concerns, problems, help with referrals, we'll do whatever we can. We have a lot of work to do yet. We have a lot of work to improve access to care. We have a lot of work to do to improve our intake process. We have a lot of work to do to improve how we deal with these things as a team. And, there's a lot we don't know, but there are some things that we do know. And that won't stop us anyway from getting in there and trying to address the real problems in front of us, even in situations of uncertainty. I mean, that's what we should be about.
Yeah, I think
so
I
guess I'd thank Linda and Bridget and the team that put this together, and for you taking time out of a Friday afternoon to visit with us. So the door is open, and it's really been a privilege to get to talk to you today.
What he just said, that's exactly what I was going to say. Thank you very much, everybody.
Both. Thank you, Dr. Lopez. Thank you, Dr. Campo. Thank you, everyone, for being our guests today. And I hope this is, again, we see you again. This is the first in a series that we're launching. So thank you for your support and your time today and interest in Kennedy Krieger. Take care.
Thank you, everybody. Have a good weekend.
Bye-bye.
Thank you.
Bye-bye.
Thanks. Thank you, Dr. Grassman.